Good evening, and thank you for joining us for our session this evening, keeping your CKD patients out of hospital and off the dialysis machine. This evening in partnership with St George Hospital. My name is Christina, and I am part of the Cesspin CKD team. This evening, I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise their continuing connection to land, water and community, and pay respects to elders past, present and emerging. I'd also like to extend that to any Aboriginal colleagues who may be joining us this evening. I would like to introduce the presenters for this evening's session. We have Associate Professor Ivor Katz, who is a nephrologist from St George Hospital. Along with Ivor, we also have Kylie Turner, who is the CKD CNC at St George Hospital. And we have Dr. Martina Gleeson, local GP and clinical lead general practice for South Eastern Sydney Health Pathways. So welcome to you all this evening.
Thank you for the welcome, Christina. I will share my slides if everybody can see them. It's great to be part of this and for Martina and I to do this together. We're going to be talking about keeping your patients out of hospital after dialysis, but most importantly, we want to keep patients with you in the primary care. A lot of these slides and information comes from past talks that I've given, some information from Kidney Health Australia, the Limbic. I also obviously acknowledge the PHN in Southeast Sydney and community health pathways. So again, I also
see the slides yet, Ivor.
Okay.
The bottom green button. It's coming up now.
Okay. So I also, just briefly, we would also make an acknowledgement to country and pay our respect to elders past and present, and for any all Indigenous Australians present with us this evening. So very excitedly, it's been a couple of years since I've got an opportunity to talk about CKD, and I think what's going to be unique about our evening together is that it's really going to be around case studies, and Martina and I are going to be doing it as if we're sharing cases. Got two cases that we're going to talk about tonight, and through these cases, we will speak about the silent epidemic. In part two, we'll get stuck into the cases around detection and diagnosis, then about management and monitoring and patient communication. Hopefully we'll have a good amount of time for Q&A and wrap up. I've got lots of extra slides if there's any things that we need to tackle. We really want it to be quite an interactive session. We're happy to take lots of questions through. We're going to be asking questions around the cases. We're going to be having a discussion, but we welcome you to participate. So the learning outcomes this evening are really going to be looking at, firstly, understanding and applying the latest medications, because in CKD, there's been some very exciting developments. We went through a 20-year dearth of new drugs, and all of a sudden we're having an amazing amount of new drugs in the CKD. We've got quite a few to discuss this evening. We're going to look at specifically the role of albuminuria. Kylie and I have actually published a few papers around this issue about looking at, unfortunately, the low number of patients referred with albuminuria, and we want people to understand just how important it is with respect to CKD progression, likelihood of developing end-stage kidney disease, but more importantly, cardiovascular disease. We've also got some clinical algorithms to support decision-making, and this is going to become quite important because this algorithm is going to be included in the e-referral adult renal pathway coming out later this year. We're looking at ways we can collaborate, specialists and GPs, and optimize kidney and cardiovascular protection in our patients. And these cases we've got tonight will do that. And then we'll look at some of those referral points for our patients, look at some safety, how we can manage them best in primary care. So, of course, I just want to give a little bit of an outline of CKD. We suspect about 1 in 7 Australians, so that's about 2.7 million people have CKD. It's twice as common as diabetes, but I think there's a strong link between CKD and diabetes. And a lot of the drugs that have been developed have come from diabetes. And we now know that these drugs also are protective just in CKD alone. So CKD is increasing as we get older and as diabetes and hypertension become more issues. And of course, for our Indigenous Australians, there's a 1 in 5 risk, so a very high risk for Indigenous and Australians, the Aboriginal and Torres Strait Islanders. But what is really important, in fact, is that if you've got CKD, very few people, only about 4 out of 20, will actually get onto a dialysis. Most of our patients, unfortunately, with CKD will die because of a cardiovascular problem, a heart attack or a stroke. So in fact, as clinicians in primary care and as nephrologists, we pretty much are managing cardiovascular protection as much as we are managing renal progression. The burden is significant. I say it's increasing. And of course, we must remember that the burden is highest if you come from a disadvantaged social background, if you live rurally, or if you are an Indigenous Australian, Aboriginal, or Torres Strait Islander. So what can we do? Well, in fact, if we detect it early and we manage it, we can probably stop deterioration in about half the patients we see. That will have massive implications for us. So much so that we can actually slow the progression, delay people starting dialysis now for as much as 15 years. And that has implications for the individuals and, of course, for our health services and just for general quality of life. So we have to get to these patients early. Only 7% of patients are aware that they've got CKD. And when we have a look, unfortunately, you're not going to be aware that you've got CKD unless it really progresses and you lose 90% function. Your eGFR is often only below 10. In fact, sometimes it can be only as low as 4 and 5 before you even start really feeling unwell. And getting referred late is a big problem because if you are referred late, your survival is worse, your outcomes on dialysis are much worse, and you're much less likely to get a transplant. And Kylie does the education of patients early on, and if we can't get to educate people early, we land up having very poor outcomes. So there is a problem. You can see here, this is looking at a whole lot of diseases in this graph, and you can see certainly back pain and other issues are well picked up in, if we look at Australian Health Survey and GP practices, but only about, it's actually a little bit higher now, as I said, about 7%, but we should actually be as high as we expect 10 or 12% of Australians to have CKD. The problem also in our practice, and especially in primary care, it's mainly patients with advanced renal failure, so stages 4 and 5. That's when the eGFR is below 20. So advanced renal failure that we get to know and pick them up in our practice, but the biggest impact can occur in the earlier stages, stage 2 and 3, when we can have the best impact and outcome. And I've told you that about 20% of Australians and New Zealanders are referred late. So if we pick these patients up early, we can teach them. Why is it so important? Cardiovascular risk, reducing cardiovascular events. I've told you probably more importantly than even the kidney progression or kidney disease. Higher mortality if you have got CKD at any age. It leads to kidney failure and dialysis, which is costly for patients, costly for our society, costly for our healthcare, and it's a huge economic burden. And the economic burden is, of course, not only the dialysis, which is $80,000 a year, but it's also economic burden. If we delay every year, we delay a patient to dialysis, we're improving their quality and improving their economics as well. So let's have a look now at chronic disease detection and diagnosis, and I'll let Martina carry on here.
Thanks, Ivor. So with the increasing focus on management of chronic disease in Australian general practice and making it easier to do chronic disease management plans, this is an opportunity for us to really invest in our patient care. And there are lots of people who are at increased risk of kidney disease. So people with diabetes and hypertension, obviously, people with established cardiovascular disease. If there's a family history of kidney failure, obesity with a body mass index greater than 30, current or past smoker or vapor, a person with a history of an acute kidney injury. So it's actually really important to code that in your practice software if the patient's discharged after an acute kidney injury event, so that that gets picked up when you're doing your risk analysis. Anyone over 60 and First Nations Australians over age of 18. So 1 in 3 Australian adults are at increased risk as a result of that. So how do we do that? We do a kidney health check, and that's pretty easy. It's a blood pressure check, aiming to keep their blood pressure below, the goals. A urine ACR test once a year and a blood test to calculate the eGFR. And this should be done on all Aboriginal and Torres Strait Islanders above the age of 18, probably as part of their Aboriginal health check if your practice is organised and doing those things. And any non-Indigenous Australian living with diabetes or hypertension every year. And then all of those other risk factors, you can also consider doing that. So often they'll come in for their routine bloods. And when you do their routine bloods, if they're at risk of CKD, just consider adding an ACR to the examination, because then you don't have to send them back to do it if you get an abnormal result. Thanks, Ivor. So case 1, this is Amit, and he's a 54-year-old gentleman who already has type 2 diabetes of 7 years duration and hypertension of 4 years duration. And he's well known to your practice. His other medical issues include obesity, obstructive sleep apnea, diverticulitis, and depression, and he's on an SSRI. And he comes to your practice and he's got a groin abscess, right? And you do some labs and you find that his creatinine is 68 and his eGFR is above 90. His HbA1c is 7.8% and his urine ACR is 30 milligrams per millimoles. So maybe you can just pop into the chat. Do you think this gentleman has CKD? Just a thumbs up or a... I think we should have set up a little Menti. Yeah. So someone's, yep, that's right. I think we more easily as GPs identify stage 3, which is what Ivor's already said, but it's possible that he might have stage 2 CKD. So he's certainly got a few other things that need to be sorted out, hasn't he? So let's go on to the next slide.
I think also just to mention, because we mentioned that probably we would also like to repeat this on 1 or 2 occasions.
I was going to say that next.
Yeah. Okay.
Yes.
Sorry.
Yeah.
Let's move on.
No, that's fine. So that was the question we've asked is, in practice, is eGFR alone sufficient to detect CKD? And, oh, good. We've got people putting stuff in the chat now. Yeah, so that's right. It's probably not. We need that ACR. That's one of the big points of today's talk is we need to be thinking of asking for that ACR. So could be I mean, if the eGFR is 40 and you've repeated and it's still 40, then they've got CKD, but you don't really know how to work out how bad it is because you haven't got an ACR. But if the eGFR is a bit higher, then the ACR helps you work out where they're at. Great. Next slide. Ivor? Thank you. This is our second case. This is a 28-year-old woman, Sue. She's a Kokomenjan female from Kawaniyama. She's an Aboriginal woman. She has had type 2 diabetes for 5 years, and she works as a land and sea ranger with education to year 7. The other medical issues she has, she's quite complex. She's got rheumatic heart disease with mitral valve stenosis, hypertension. Her father's from the stolen generation. Her mother's been told she's got CKD. She's a non-smoker and non-drinker of alcohol and lives with her partner and son of 18 months old. And she had preeclampsia during her pregnancy. So her labs show a creatinine of 45 with an eGFR of greater than 90, but an HbA1c of 9.5% and her ACR of 76. So do we think, and she's presented with a UTI. So are we able to say if she has CKD for this one? There's a lot of people saying yes, but somebody else has rightly pointed out that an infection of any kind, but especially a UTI, can affect the ACR. So we probably need to repeat this test when she's recovered from her UTI. Ivor, how long would you delay it once the UTI is cleared? Would a couple of weeks be it, or do you need to leave it more than a month?
I think a couple of weeks. I think when you're sure you've done a dipstick and there's no activity, if they've had a significant infection, a pyelo, then I would wait a little bit longer and maybe reculture. But I
if
think
it's
just
been a cystitis and they're symptomatically cleared and the dip shows no nitrates and no white cells, we could probably go ahead and do an
absolutely.
ACR.
I agree with you.
Thank you. Next slide. Oh, actually, we'll stay on her. So she's got a lot going on, right? And people have pointed that out in the chat. She's got her rheumatic heart disease, and hopefully she's receiving the treatment she needs for that. We don't know what medication she's on for her hypertension, but the preeclampsia increases her risk as well of developing cardiovascular disease and kidney disease. So, and her HbA1c indicates that her diabetes is quite poorly controlled. So there's a lot we can do for this woman already. Next slide, please. So with these two people in mind, let's have a talk about chronic kidney disease management and monitoring. Once we've identified our at-risk patients, we should really be doing their kidney health check every 1 to 2 years. As we said before, blood pressure, creatinine and eGFR, spot urine, ACR, and then repeat it if it's abnormal. Even the patient was well when you did the first kidney check. And then you can use a staging table from the Australian Kidney Disease Guidelines. On your left, you'll see all of those people that we listed. The other slide said people with diabetes and people with hypertension, but really we should be offering a kidney check to all of these people. As you know, and we're probably seeing them to check their blood pressure. So it's easy to throw in an ACR and check the other things as part of it. And Kylie reminded me that it's World Kidney Day on Thursday this week. So it might be a good thing to be saying to yourself this week when you go back to your practices tomorrow, who should I be doing a kidney check on that I haven't done for a while? Because once you start doing those screening tests, you sort of get them back and start to manage them. Ivor, there's a question in the chat asking what's the role of renal ultrasound? And I think that probably means you wouldn't do it as part of the kidney check, but once you've identified kidney disease.
Yeah, I suppose in these two patients, you've got an argument. One's had a urinary tract infection, so a non-urgent ultrasound would always be good, just to make sure everything looks okay. The other patient, yes, I suppose, when we talk about CKD, we're also talking about patients who could have polycystic kidney disease, and you're not going to pick that up
unless you do an ultrasound.
Unless you do an ultrasound. So,
I guess once you've identified kidney disease, an ultrasound, I don't know, not a staging ultrasound, but an ultrasound to look for a cause to understand what's going on is probably a good idea.
Yeah, and I think if you've got hypertension as well, as I said to you earlier, judge signs by the company they keep. If you've got hypertension, look for the other bad signs that may go with it. In those
Yeah.
type of patients, I would screen.
Would you screen with a renal artery Doppler for someone with hypertension?
No, not necessarily first up, unless maybe I found a differential size in the kidney. Then I'm starting to think maybe there's a renal artery stenosis, or perhaps in a younger person, if you're suspecting those things. But generally, I would just start with an ultrasound. But I don't think in every single person you'd have to do it. But I think once you're getting CKD, it's always on my checklist.
Yeah. Yeah. Okay. Next slide, please. So then, we've identified someone who has CKD, or someone who's at high risk. We should be using our recalls and reminders to call them back after they've had that kidney check, and making sure they are recalled or a reminder comes up to do that in another 12 to 24 months, depending on what their other risk factors are and how concerned you are about them developing kidney disease. We should also be using the cardiovascular risk calculator once we identify someone with kidney disease, because in the cardiovascular risk calculator, the first question you have to ask is whether they have moderate to severe kidney disease. And that's if they've got a sustained eGFR of less than 45 or a persistent ACR I had it highlighted to show persistent ACR greater than 25 in men or 35 in women. So once they've got that, they tend to be coded for having a higher risk of cardiovascular disease. So it's worthwhile using that calculator with your patient when you've picked up that they've got kidney disease. Look at their other CKD risk factors, and especially for patients who are middle-aged, we can use our health check item numbers to be doing that sort of thing. We can put it into a 699 or one of those 40 to 45 plus health checks that you can do. And then once you've diagnosed CKD, we can use our chronic condition management plans to set up reviews and set up our goals of management. And we don't need to be referring necessarily at this stage, but setting that up for your patients. I work in a private billing practice, but we bulk bill our chronic disease management plans and reviews. So that gives a person who's going to need to see the doctor more frequently than many of their peers, more affordable healthcare if we can utilise those item numbers. And then we can also, using our practice nurses, if they're well trained, to monitor their progress using the 10997 item numbers, make sure that they're adhering to treatment, and maybe even using a medication management review to make sure that we haven't got them on anything that could be making their kidneys worse. Another question, if they have we asked about the renal artery Doppler, but another question, if they have cardiovascular disease, should they have a renal artery Doppler? As far as I know, that's not in any of the guidelines as such. Yeah.
Yeah, I'd agree with you, Martina. I wouldn't do it, unless you think there's a secondary cause. And generally, the only way you're going to pick that up is if there's a differential size in the kidney. The other group that I would do it is if they're hypertensive and they resist it.
Yeah.
Not resist. Yeah. So you've got them on 3 agents and a diuretic. Yeah, I for sure would go and do a Doppler, because now something's abnormal and you're starting to think of secondary hypertension. So yeah.
There's another question, which is, I think the answer is subtle, and that is, does eGFR vary with aging?
Yeah, so that's a great question. And in fact, I've got some nice slides at the end that I'll show you.
So we can hold that question.
Yeah, we can hold that question, but I'll tell you, in principle, from the age of 40 to 45, you lose 1% of your kidney function a year. So you can calculate that, and I'll show you in a graph how that will look.
I mean, it must, because I get surprised when I see a 90-year-old with perfect kidney function. It's something to celebrate, but it tends to be
and
too
probably
severe. And very rarely with proteinuria, often just a little bit of a drop in the eGFR.
So you're exactly right. So that type of person, I wouldn't say has got CKD, but they
Mm.
probably have got fewer nephrons for sure.
Yes,
And
yeah,
probably the remaining ones are going to be hyperfiltrating to get you that GFR.
to make up for it.
And
Yeah,
that's why the 90-year-old, when they do get a small illness, will get AKI quickly.
AKI, yeah,
Yeah.
yeah.
So that's the important
Next,
thing.
next slide, please. So these are things that we can all do to help our patients with kidney disease is talk to them about what changes they can make to affect a small weight reduction. And yes, we aim to get them into the healthy weight range, but we also know that metabolically, if we can get an overweight patient to lose 10% of their body weight or 10% even of their excess, that has improvements on all of their metabolic markers. So, but it can bring your blood pressure down by 4 millimeters for about 5 kilos of weight loss. So that's a good thing to do. This is mostly about blood pressure because blood pressure can drive kidney disease. Reducing dietary sodium intake to no more than 2.4 grams of sodium, which is 6 grams of salt. That reduces the blood pressure by about 4 to 7 millimeters of mercury. The DASH diet can help, achieving up to 11 millimeters of reduction for people who are hypertensive, increasing their physical activity, which just helps everything, doesn't it? Diabetes, cardiovascular disease, COPD, and then reducing their alcohol consumption to a moderate level, no more than 2 drinks a day for men or 1 drink a day for women. You have to be careful with asking them how many drinks they have. I was asking a woman about this week. How many glasses of wine do you have? 1. I said, and how many times does that 1 glass of wine get topped up? And so that bottle of wine, how many nights does that bottle of wine last you? 2. So she's actually having 3 to 4 standard drinks a night. So you've got to just. I like to ask them if it's a bottle of wine, how long does that last you in the week? Because 1 bottle of wine should last a woman 1 week, however she does it, and that can be pretty much of a shock to some people. All right, let's go. Next one. Thanks, Ivor. So these are the key management strategies that we can implement in primary care to manage CKD. So we want to reduce the albuminuria and the slow decline in eGFR. We want to maintain their blood pressure below 130 on 80 and lower their cardiovascular risk, because remember, that's the cardiovascular risk that's actually a higher risk than the dialysis risk for these patients. Try and avoid further damage to the kidneys. Oh, you wrote this is a sorry. I think it's all of the above except for number
Anyway,
5.
you passed
I passed the
with flying
test.
colors. Well done. Okay. So I think we know now that you should not do nothing.
Yes. Yes, I think we agree with that. All right. So these are the key management strategies as we just went through. And there's I don't know if everyone's seen the Australian CKD handbook, but it's one that's worthwhile bookmarking and having on your desktop. But there's also an app that I use, and it's called CKD Go. Oh, isn't it horrible when your phone just starts wanting to talk to you when you're trying to? Anyway, I can't find it. I had it up ready for the thing, but it's called CKD Go. And when you put in, here we go. I don't know. What if people
In the
do?
meantime, Ivor, there's a couple of questions in the chat. Oh, there we go. Oh, no, I think
Do
because
the
you've got the
fancy.
blur on.
Yeah, but basically
I've got a
you
slide
can,
later just to direct people to that.
yeah,
So
you put in the ACR and the eGFR, and it basically tells you what level of kidney disease they have, and then it has a care plan for you. So that can be really helpful. Did you want to ask the question, Kylie?
There's a few in there. Is there a seasonal change in eGFR?
Oh,
no.
No. If creatinine and GFR are abnormal with blood test results, when do we need to repeat the test?
So I think the guidelines say to us that you should be repeating EGFR over at least 2-3 times over a 3-month period. So the first one and then at least 2 after that. And the same with the ACR. You do want to repeat it. In our case,
this is when you're establishing what level they are.
Yeah. Generally, when you're tracking disease, and we'll discuss that again, definitely if you're starting to treat and manage with medications that should be reducing albuminuria, you definitely would track it. I think that it's covered on the PBS to do it at least twice a year, a urine ACR. So I certainly think that's reasonable in primary care. To save one, sort of to make the diagnosis first up, you may do 2, and then, over the next year, the next year you'll be using those ACRs to track response to medications. And I'll cover some of that a little bit later.
Yeah, and I think because we're on a 3-month cycle with our CCNPs, I think that first year after you diagnose CKD in a patient is a really good time to do a lot of as much intensive intervention as you can get away with the patient by introducing the medications we're going to talk about and then monitoring their response and then making adjustments. And so once you've established that they've got CKD and you really want to try and reverse their trajectory or slow down their trajectory, seeing them every 3 months and remeasuring their EGFR and their ACR and then looking at what other things you can do for them is a very reasonable thing. And I think you could very easily justify ordering the blood tests that often to the PSR because you're trying to save the economy money from having people on dialysis or having heart attacks. So, and probably once you've got them stable, you might not measure it quite as often, maybe every 6 months. But the CKD guidelines actually also advise how frequently you should be doing the blood tests based on what their levels are. So there's another question.
Another 2. There's 2 there, actually.
And what I might do is save those ones for the Q&A at the end so that we can keep going through this. So, Christina, can you put them into the Q&A and we'll save them for later on because I do want to answer them. Okay. So all of these things, avoiding further damage to kidneys, maintaining blood pressure at target, reducing albuminuria, and we're going to talk about how to do that, slow down the decline, lower their cardiovascular risk. Next slide, please. Okay, so we're back to Amit, and unfortunately, he didn't get his intensive intervention, so he's come back to see you 2 years later, and he's 56 years old. He's now had type 2 diabetes. Oh no, I think that 7 years was already, and he's come back this time, and he's complaining of severe fatigue. So you repeat his investigations. And now his creatinine is 123 and his EGFR is 57, which you still might look at and go, that's not too bad. His HbA1c is 12 and his urine ACR is 76 and his hemoglobin's 131. So I think we're going to show you the graph to work out what grade CKD he has. So looking at these CKD stages, I think we call this the heat graph, right, Ivor? Yeah, so with his EGFR between 45 and 59 and his ACR greater than 25. Go back. Go back. He's stage 3A. Okay. So at this stage, have a think. Should he be referred to a specialist? I'm not going to answer the question. And our next case is Sue, our now 30-year-old Aboriginal patient who has presented with polyuria and frequency, and she's worried about another UTI. And you do some further investigations. And her creatinine is 116, her EGFR is 55, her HbA1c is 9.5%, and her ACR is 76, and her urine culture is negative. So going on to the next slide, her level of CKD is somewhere between 2 and 3, or is the cross moved?
has moved. She's also sitting 3A.
She's 3A, yeah. So should she be referred to a specialist? Hold those people in mind. Next slide. So these are who you refer. If they've had a rapid decline in their eGFR, and remember, both of these patients have been seen back after years. So we can't really make that judgment because we're talking about more than 15% over 3 months. Or if they've got acute nephritis, so that's decrease in urine production, hematuria, acute hypertension, and edema. They probably even, would you send them to hospital?
Yeah, I think those
Yeah.
those ones would fit into the acute criteria, referral
Yes, I
criteria.
agree. I think they would too. Yeah. Or you refer if their eGFR is less than 30, or if they've got a sustained eGFR decline of 25% within 12 months, or 15 mils per minute over 12 months, or if the ACR is above 30, but that's interesting because both of them had their ACR above 30. Somebody's asked a question about difficult to control blood pressure on at least 3 agents, including a diuretic. So this is regarded as resistant hypertension, and that would be another reason to refer with a combination of CKD and resistant hypertension. Or if they're a First Nations person, we refer them earlier. So if their eGFR is less than 45 rather than 30, or if their ACR is greater than 30.
So I think this is probably worth a little bit of a discussion, because this is pretty much from the handbook and the CKD Go app suggesting that you do that. And I think as I was speaking to you earlier, when I speak to a lot of GPs, patients can't necessarily, or out in rural areas, you can't really refer somebody with a urine ACR. Would you refer Amit along to a specialist just because the ACR is above 70? Now, it is significant. It would fit in the macroalbuminuria range. And I think there is a lot of questions around this, and things have changed. And I think that's one of the reasons why we're doing this talk tonight, because it has been accepted now that you should be individualizing your patient's risk. And we'll go through some of that now in the next couple of slides.
And we're talking about patients who we want GPs to recognise that stage 3A kidney failure and kidney impairment and do something about it. And even if I've got a patient, Ivor, who is well resourced, and they live where I work in the Sutherland Shire, where there are plentiful supply of nephrologists in walking distance if they walk well from their house, right? But they still might have to wait a little while before they get to see that nephrologist that they're paying privately to see. And there's stuff I can do in between, which we're going to talk about.
Yeah, and I can tell you that in our paper that we published, if you've got 2 and 4 together, you almost always will have a risk score that is more than 3%. But I think the key thing is, if you do have those eGFR less than 30 or a urine ACR separately, I think in those instances, you should be doing what I'm going to be telling you next to do.
Great.
So I think this is now in the KDIGO guidelines. This is the International Society of Nephrology guidelines. And it's now accepted as the next sort of level test to be doing in primary care or in tertiary care. Now, the problem with the heat map gives you a relative risk of progressing or having cardiovascular risk. And of course, if you've got significant proteinuria, I'll show you that you do have a higher risk of cardiovascular disease. But it's only a relative risk. And referring a patient onto a specialist is a big thing for a patient, because 9 out of 10 people will want to know from me straight away, am I going to die? Am I going to land up on dialysis? And that is a very big question that they're asking. So the kidney failure risk equation score, which I'm going to be speaking to you about, it's called a KFRE score. It's been validated in Australia. It's been validated worldwide. And there's, in fact, a specific KFRE score for Australians that's going to be included in the e-referral New South Wales adult referral guideline. But what the KFRE does is it now takes into account a number of various parameters and individualizes that risk. And we currently, the most important one for you is that you would usually refer here when the eGFR is from 30, you would transition from primary care to a nephrologist. But in fact, I'm going to just show you. So here at this point here, this is where you would refer. In our situation, we actually calculate the KFRE score. It's the kidney failure risk score. It's available online, and I'm going to tell you about it with respect to Amit and Sue. And in fact, Kylie and I even use these scores to make decisions about referring patients for vascular access. So this score is actually a decision point assistance score, and it helps you decide around transition to care. And the general advice is if the KFRE score is more than 3%, that patient probably should be under specialist care. The truth, though, is that any risk below 10% is low. And to put it into perspective, to have a risk score more than 95% 5-year risk will probably mean you'll start dialysis in the next year. So there's a big jump going from a 3% risk of progression to renal failure requiring dialysis to 95%. And we're going to have a look at it specifically now. We're going to calculate the risk failure score, and you're welcome to do it with me now. You can just type in on your phone kidneyfailurerisk.com, and you will get this web page here, and you would there's a little icon that says calculate the risk, and the risk score that we would calculate with Amit and Sue would be using their age, and I think Amit was 56, and we would be using his ACR. So his ACR, if you remember, was 70, above 70, so say 75, 76. So that's macroalbuminuria. Certainly it meets the criteria for referral according to the kidney health and the heat map. But actually, when you calculate, and it's also based on his gender and also where he is in the world and his urine albumin creatinine ratio. And I think what you have to understand is that what this algorithm does is it creates an interaction between age, albuminuria, and GFR. And you start realizing when you use this equation often that albuminuria becomes a very, very important component of patients' kidney disease and cardiovascular disease. So in fact, you can see Amit, he actually only has a 5-year risk of developing renal failure requiring dialysis of 1.8%. So as Martina and I were discussing earlier, she tended to say, I could quite happily manage this patient in primary care. His HbA1c wasn't right. His blood pressure didn't look okay. You really could focus on all of those things that will have. He's got albuminuria, and we're going to talk about some of the new drugs that are out there. Sue, on the other hand, is 28, and having an ACR of 75 or 76 or 77 at her age means she's got many more years to develop renal failure. So her risk score at this particular point in time is 3.23%. And definitely in this case, she's somebody you would want to manage together with a nephrologist or a specialist. So calculating the KFRE score really does help. And this slide is probably going to be the most important slide that I'm going to show you tonight. I'm going to try and make
it. Can you just go back to the KFRE for one more? Sorry, Ivor. There's a question in the chat saying this is not on the CKD Go app, and that's correct. But it is in the health pathway, even though our health pathway needs to be updated. And it is a helpful thing to add to your assessment, even though it's not in the Go app, because it will be used by the public health system to triage your referrals. So it's helpful for you to be able to predict, look, that risk is 1.8%. I'm going to have to keep on managing this patient instead of waiting for their appointment to come up in the public system, which might be a 365-day wait. So,
So exactly. So Amit's going to be a category 3 weight. We've been using the KFRE score for the last 8 years already to help us triage in our unit, and we've published on that. So You can see that article in the Internal Medicine Journal. You're welcome to look at it. And we showed basically that we probably, and we've been pushing, and I sit on the Kidney Health Australia, and I think it's a brilliant organization, but the evidence is now coming out stronger and stronger, and I suspect the next guidelines will include a KFRE score. But we are already going to be using it as a risk prediction and a triage tool. And also, what is really nice about this page, and I haven't shown it to you here, is that when you actually calculate the risk and show it to the patient, further down on the web page, you can actually show the patient how getting blood pressure control will reduce that risk. You can show them how adding an ACE inhibitor will reduce the risk, and you can show them how the newer agents will also reduce the risk. So I use it very often in my consultations also as a tool to explain why I'm using certain drugs and as a motivation for patients to be involved in their care. So this is the reason why a urine albumin creatinine ratio is just so important to do, and why the KFRE score includes it, why this algorithm allows it to do it. So let's just have a look at the progression of Sue and Amitia. Their GFR is somewhere around 60. They are both in the red range because their urine albumin creatinine ratio is in the macroalbuminuria range. And you can see they have a 64 times increased risk of progressing to their CKD progressing. Not necessarily to need dialysis, but certainly will progress over the next number of years. Of course, as we said, Sue is young, so she's got many years to progress, and so she's much more likely to progress to end-stage kidney disease if you have a look on the left-hand side here where it looks at risk of progression. So in fact, her risk of progression is again 64 times also of getting kidney disease. So if you can reduce the albuminuria, you can convert somebody's progression from 64 times to around 7 or 8 times. But more importantly, I told you most of our patients with CKD are unfortunately going to die of cardiovascular disease more likely. And having that albuminuria in the macroalbuminuria range at 75 is giving them a 4 times increased risk of cardiovascular events. Whereas if you could get that albuminuria down, it's 1.5 times or 2 times. These are very significant events for patients. It has impacts on all-cause mortality, acute kidney injury, and what I haven't included, but in the later trials, it's even showing you hospitalization. So urine albumin creatinine ratio, if you are not doing it on a patient who's got CKD or at risk of CKD, you really are disadvantaging your patient, and you're also not helping make the decision support for your patients and decisions. So what do we do? And these are the key things that we're going to do. Now, I'm going to just focus on the second point because this is from the very key trial, and I always forget the name of the trial, but essentially this trial was done and published by Australians. Prof. Perkovich was his trial, and they essentially just took these patients with CKD, eGFR below 45, and they put them on simvastatin and ezetimibe, and they had a 20% reduction in cardiovascular risk, just simply being on it. They didn't recheck to see what the cholesterol levels went to, so there was no monitoring of lipid levels. They were just simply on this trial, and there was significant risk. So if you've got patients who meet those criteria, and when you've done a cardiovascular score, risk score with CKD, you certainly would put these patients immediately on a statin. But what has changed?
Independent of what their cholesterol was, isn't it? Like if their cholesterol was 4, you'd still put them on this.
It was independent of their cholesterol. So it was just because their cardiovascular risk was increased with CKD. So if I see a patient with a GFR less than 45, I put them on combination ezetimibe and simvastatin, because with a GFR below 45, you're at increased risk of cardiovascular events. So the other trials, what has really been, and the other key aspects of our talks tonight, is focusing on the new drugs on the block, the SGLT2 inhibitors, dabigatran, empagliflozin, which we've now got available. These are initiated with any patient between 25 and 75, or below 45, and above 25, you're going to start them on the drug no matter what their ACR is, and I'll show you that evidence. And equally so, you're going to start them on SGLT2 inhibitor if they've got albuminuria more than 22 milligrams, or even 20. Most people will just say 20 milligram per millimole, and an EGFR below 75. So SGLT2 inhibitors are added on top of ACE inhibitors, and these are amazing new drugs that we have. As I say, these drugs, ACE and ARBs, came out in the early 2000s. It's been 20 years since we started getting these new drugs, which have been amazingly impactful on declining kidney function. And I'm going to show you some slides. Certainly, evidence is now supporting using non-steroidal mineralocorticoreceptor agonists. So these are specific drugs. They are mineralocorticoreceptor agonists like spironolactone, but these are specifically non-steroidal-like, and the one that we use is finerenone, and we use it only in type 2 diabetes. So if we've got a patient with CKD and type 2 diabetes, we'd be adding finerenone. And of course, there is the FLOW study, which I'll discuss, showing you that GLP-1, although we know it and everybody knows it, and when I see my patients, of course they know it, because everyone knows Ozempic is in the news, but they understand it to be for obesity. But there is now the FLOW study showing that it's also beneficial in CKD. So if you've got a patient with CKD and type 2 diabetes, you have to have, these are the 4 pillars. There are lots of studies looking at how you initiate them. Most nephrologists initiate them in a stepwise approach, but that is not always. There's quite a few studies showing if you've got type 2 diabetes, people initiate the SGLT2 inhibitor and the non-steroidal MRA together. And of course, the GLP-1s in Australia are really only for PBS, for obesity, but the evidence is for CKD alone. So we have to, it's probably going to come in the near future where it will be PBS approved. But certainly we've got to be looking to see how we can get our patients onto these drugs. And I've got lots of patients who have got diabetes who I managed to get them on. And I think, Martina, you were saying you have as well. And
yeah, I thought it would be good to, while we're looking at these pillars, are we going to go back to the patients? Yeah, I thought it would be good to talk through how we would approach each of the patients with these pillars in mind. Do you want to do that now, or do you want to do that when you've done your next few slides?
Let's just go through. I think we almost close to finished. I'm going to
yeah, sure. Sorry to rush you, but
no, not at all. I'm just going to show you, these are the key studies that started coming out over the since 2022. The Credence study, they looked at diabetes only. The DAPA CKD came next. That included patients with CKD, and that's where we got this number 25 to 75, and urine albumin creatinine ratio more than 22 milligram per millimole, which is what we use. We don't use milligrams per gram. And the EMPA trial showed this more than 45, less than 75, and an ACR more than 20 milligram per millimole, or if a patient's between 20 or 45, and no matter what their ACR is. Actually, Forxiga now has got the same PBS approval, so they are equal. You can use dabigatran and empagliflozin Jardiance in the same way. So the evidence is pretty much there. And this is really what you're doing. I spoke to you about that 15-year survival. So if you had Sue or Amit and we put them on that trial, this is the person who's on the placebo. Within 10 years, they will decline. And their GFR, I told you, on average, when you get above 45, your kidney function declines by 1% a year. Their kidney function is likely to decline by 4.5%, 5%, 5 mils a year. When you get these patients on SGLT2 inhibitors, you can start delaying and getting it pretty close to the 1 mil per minute or 1% a year decline. And you can see getting it at 50, by the time the eGFR goes below 10, we're looking at another 25 years. So you've delayed their need for dialysis, but you've also reduced their cardiovascular morbidity and mortality. These trials were quite unbelievable and way better than ARBs and ACE inhibitors in cardiovascular risk reduction and renal protection. So we have to use them together because they are additive, and certainly we would use it. This is evidence from the FLOW trial looking at GLP-1, so semaglutide, Ozempic, all the other ones that we've got available. Again, 24% reduction in cardiovascular risk, any cause of death, and slowed the kidney decline to, on average, 1%. So just over 1%. So again, very significant differences and improvements in decline in renal function. So you can see that the evidence for using these drugs is very strong. This is looking at finerenone, which is Kerendia, for patients with type 2 diabetes. Again, marked cardiovascular, 86% cardiovascular risk reduction, kidney disease by 77%, and similar reductions to SGLT2 inhibitors. And using them with an SGLT2 inhibitor is additive. So you really got to get our patients onto these trials. So how do we communicate with the trials? Well, I often explain to patients where the kidneys are, because of course we know where they are, but they've got no clue. I explain about these filters, where they sit and how they work, and how your kidneys the size of fists are able to, filter one and a bit liters every minute. And I explain to them how tiny these little filters are with these little blood vessels that can easily be knocked out by hypertension, and easily be damaged with diabetes. And I also explained to them how ACE inhibitors work, and we know ACE inhibitors work on this efferent arteriole. We know that SGLT2 inhibitors work over here, and they certainly do. There's certain nuances which we can go through and discuss about how to use these drugs over the next half an hour and what the risks that you do, but that's the type of thing that I would do. I know certainly in the rural areas, I don't know if you use this, Martina, but this was from one of the CNCs that I worked with, who works out in in Queensland, and they use this to explain proteinuria and blood pressure and how that impacts on kidney function. So there are lots of tools there. Of course, this is the heat map, which we've told you, and the heat maps are important because if you're sitting in those red areas, they are telling you that you've got more proteinuria, more CKD, worse CKD, you've got higher cardiovascular risk. So very important to tackle. And of course, I've told you the individualizing the risk. And I said to you, using these KFRE scores also shows you when you add on an SGLT2 inhibitor, a gliflozin, you can show the patient, you could show Sue that now that you're on the gliflozin or Jardiance or Jardiance, whichever you're using, that look, your risk was 3%, but actually now it's down to 1.5 with your blood pressure controlled, and so on. So very important with these drugs, because we're using a lot of these drugs now, this is a new thing that I really try and cover in my consultation, is a sick day plan. I always give a printout of their medications and explain that you should stop them if you're dehydrated, you're unwell, even if it's for a week. These are drugs that are long-term insurance policies, not short-term, and therefore they are available in the handbook. You can get them printed out. That one that we're showing you there, that sick day plan, you'll find on Kidney Health Australia. And this is just a mnemonic to remember the drugs that I always tell them to be stopping, and just reminding me that these are the ones that are common to withhold in your sick day plan. Of course, the ones we're using are ACE and ARB, the SGLT2 inhibitors that I'm often circling and telling patients just to stop. So I'd imagine we use all of these things. Martina, you're using an app for visual material. I told you I find different ways. We all find different motivational ways of getting our patients involved. Using the KFRE score is a very helpful motivation. Making patients understand how proteinuria damages the kidney. I often explain it to them. and why it's so important to get rid of, because it causes scarring in the kidney, and all of those things are quite important when we sit and speak to them. I don't know if there's anything you want to speak to in this slide, Martina.
I mentioned when we were talking about it, asking the patients to take all of these tablets is actually quite a high pill burden. And so it can take a lot of motivational interviewing to get them to see the benefit of taking the tablets to avoid having to go to a hemodialysis 3 times a week. But I think part of the motivational interviewing will be seeing things improve. And I must admit, Ivor, I probably wouldn't give them 4 new tablets in one appointment. I'd probably plan to do it over a year, introducing things and seeing the response. Hopefully, if I've got them engaged, I'll get them back. One of the strategies I use when I'm dealing with people with chronic diseases, I book their next appointment before they leave the surgery, so that it's in their diary and they don't go, oh, was I due for a checkup with the doctor? It's already booked in, it's in their diary. And that makes it easier to then go and give them the blood test form for the next blood test, so that we can go, look how well this is doing, now let's add this one, right? So
Martina, I do exactly that. And I think most nephrologists do the same. I think maybe in the future I may, because SGLT2 inhibitors are actually quite a bit safer in many ways than ACE inhibitors. They do cause a slight decline in renal function, but it's pretty stable. They don't get hyperkalemia. You can warn them about drinking a little bit more. So I sometimes will, and I'm tending towards using finerenone if they're type 2 diabetics with the SGLT2 inhibitors. But I tend, as do most nephrologists in Australia, add it on. But what I do is I ask my GP colleagues who I'm sharing the patient with, I've just started this drug. Can you start the finerenone before I see the patient next time?
Yeah.
So we start sharing, and equally so, if you've seen I've started an ACE inhibitor and I've started it, maybe you'll add the GLP-1 because you can see it's a PBS and you can get it on for the diabetes. So we have to be using these drugs, because if we wait the same, it took us 20 years to feel comfortable using ACE inhibitors. We can't afford 20 years before we all start getting comfortable. And we do have to, there are going to be times where patients get sick. We have to stop these drugs, restart them again. And if we're doing it together, we really can start them quicker. So I totally support your approach.
Can we go back to the patients and then talk through
so
how a GP might address this?
Let's go back, and then we can start having a bit of a discussion and answering some of the discussion points. And I'm happy to go and look at
So let's look at Amit first.
Yeah.
So he's got type 2 diabetes. His HbA1c is 12%, and he's got CKD. So, but I would be probably focusing on giving him the diabetes medications that are going to help his kidneys. So I would start him on an SGLT2 that day because he meets the criteria for PBS. Then you can't start the GLP-1 for diabetes until they've had a clinically insignificant response to their SGLT2. And effectively what that means is if their HbA1c is still above 7 after a 3-month trial of the SGLT2. So I would say to them, we'll do your bloods again in 3 months. They will have come down. I doubt they'll be below 7. And so we'll start your semaglutide injections to help you manage your diabetes and shift some of that weight after you've been on this new medication for 3 months. And they would be, because he's diabetic, they would be where I would be focusing. And then I'd be, can you tell me the PBS for the finerenone? Because I'm not as familiar with that one.
So the finerenone is exactly the same as the SGLT2 inhibitor. It's 25 to 75 and a urine ACR more than 20. Of course.
And they have to have diabetes as well as CKD, is that correct?
They must. Yes. It is for diabetes. So that's unique. And remember, it doesn't have to be after the 22 milligram per millimole does not have to be.
Is that any time?
Any time. So if they've had it before you started the SGLT2 inhibitor and all of a sudden you drop it down to, which you often see, there's often a 50% decline. In fact, if you get a 50% drop in renal ACR, no matter what level you're starting from, you've markedly reduced that person's risk, cardiovascular and progressive.
Yeah.
But it doesn't mean now that it's 7, for example, that you can't start the finerenone. It's at any point that you've done an ACR and it's more than 22.
Right. Yeah. So that would be my approach. I mean, obviously, I'd be using an ACE inhibitor for his hypertension as well, which I think he's got. Oh, no, he doesn't, but she does.
We didn't really discuss
he
the
does.
drugs, but he would probably be, and
I would expect he would be on an ACE inhibitor already.
Yeah, I
and
think he's going to
probably
be on a lot of,
metformin.
he'd probably be on a diuretic. He's a good one for MRA because MRAs work like spironolactone. So if you get resistant hypertension, let's say you've got this patient on 3 agents. Let's say you've even put him on combination therapies like Exforge, where he's on valsartan, amlodipine, and a thiazide. Now you still can't control his blood pressure. He's got resistant hypertension. Spironolactone is the drug that we often go to in these type of patients. But in this patient with type 2 diabetes, I will use finerenone as the MRA. So, and it does have some antihypertensive effects.
So and just playing, that's good. And then just playing the PBS game. SGLT2s, if you're just treating diabetes, you can't be on an SGLT2 and semaglutide, both on PBS prescriptions. And so for a diabetic without kidney disease who needs semaglutide, I would give them the semaglutide on the PBS and the SGLT2 on a private script. But if they've got chronic kidney disease, like they can have the semaglutide for the diabetes and the SGLT2 using the authority number for chronic kidney disease. So they can have both of their medications on the PBS if they've got the CKD as well as the diabetes.
Absolutely. And then there's also the angle of cardiovascular disease.
Absolutely. So you've got to add in their statin.
So we've got to be looking at all these angles, where we can use these drugs and how you can get them onto all of them. So I would do exactly the same. I think you GPs are better than me at like sort of navigating how to get the PBS.
We have to navigate the PBS. You don't have to do as much. Well, you do, but...
But I think that is exactly right. That's how I would do it. I also would say to somebody like Amit, who let's say he wasn't diabetic, I would be saying, and let's say he was obese, or I would say to him, it may be worth your while to self-fund it. It's getting cheaper. If they can afford it, not everybody can. I suspect in time it's going to be PBS approved. The problem is that it's still a production problem, and I think the government's aware of that, so they're still focusing on. But you can give 50%, of the dose, and that means you can last twice as long, so it reduces the cost by half, and that still potentially will give you CKD protection. So I'm often using it.
It's got obstructive sleep apnea, so it's probably going to help that as well.
Yeah.
If we look at the other lady, so she also has got diabetes, so I'd probably take the same approach to her. I'd be sending her off to the nephrologist, but also saying, but I don't want to wait, so let's start some stuff and have her on medication as soon as I can get her on it. Hopefully the closing the gap for her as an Aboriginal woman will make the medication burden more affordable for her, because that's a consideration. She's young. We really need to try and keep her kidneys healthy for as long as possible.
And the thing with the patient like this, let's say she is far away from a city at this point, and she's going to see only a nephrologist in 8 months. Often now in the e-referrals, she would get referred, and you would be saying, okay, can you start this drug in primary care?
That's one of the nice things about the e-referrals as they come on board, is that there is the capacity for the team to be sending some advice back to the GP. And with CCMPs, we can actually use them to get the process rolling and involve our practice nurses. So that can be really helpful.
I think again, I'll make the point. I told you that slide on the ACR is so important. The e-referrals is going to require urine ACR. when it becomes, at the moment, it's not yet, but it will be. But I don't want GPs to look at it and think, oh, what a pain in the, that I have to do it. I think you must look at it and say, well, I understand now why ACR is so important, because it also allows me to give advice. It helps you to make decisions. It also helps you to see when you start the SGLT2 inhibitor and you don't get a decline, that maybe you'll push for the GLP-1 a little bit more to get that ACR decline. Because the more you can drop that ACR, the more likely you are to improve cardiovascular risk.
Awesome. At the end of your talk, you've got some...
Yeah, so I think I've got some nice slides. So the one question that I'll get to first was somebody asked me about...
There's a few questions, but I just wanted you to be able to look at the resources. So the back one. Go back one.
Yep. There we are.
That one, yeah.
So this is where you'll find the handbook. You can just simply type in CKD, GP CKD Management Handbook, and you'll get the Kidney Health Australia handbook. I often will get it that way. So I would strongly, for those of you, I'm going to show you the CKD Go. If you put your phone over that
QR code,
thanks, you're going to be able to download the CKD Go app, and it's pretty much the book on your phone. With lots of resources. It also helps show the patient as the ACR has gone up, it changes color. So it's quite nice for the patient to also visually see. That's a great teaching tool. So certainly, and you can go equally, so you can type in CKD Handbook or CKD Go app, and you'll be able to find that on the internet. And then there is the Kidney Health Australia does offer GPs who want to become more expert in kidney health. They offer opportunities to, within your practice, to become an expert, and there's a whole lot of other options to get education. You get access to all the webinars that we do, but that's available for everybody as well. So anyone can just get the Kidney Health Professional Hub, become a member. So these are some of the take-home points. I suppose we've said it's quite common, it's serious, it's treatable. We've spoken about the kidney health check for every person, definitely for hypertensive and diabetic patients every year. I've tried to highlight how important the ACR is. Only 30% of patients referred to our unit actually have an ACR. It's probably it's the best predictor for mortality and progression. So it's very important to do it. And it's covered. There are all these new medications now that you really have to do it, and we have to do it together in primary care and nephrologists. Together, you're not going to be able to do it, and it's going to become important understanding the KFRE score and these risks when we start categorizing into emergency, Cat 1, Cat 2. So all of that's going to be in the adult nephrology statewide referral criteria. So I think that's pretty much it. Great. But I will go straight away to the one question that
We've got quite a few questions actually. So
I'll just go to the one because you asked it first, whoever it was. So this is just what I often explain to patients. So when you get to about 45, you start losing your kidney disease by 1 ml per year. And really, this slope is what we have to tackle. And in fact, later on in kidney disease, Kylie and I, in normal patients, it's about 1% a year. But if you've got hypertension or diabetes or polycystic or a GN, you can have decline up to 5, even 7 or 8%. So with all the drugs that we're tackling now and diseases like IgA, nephropathy, we're tackling the ACR. It's very important, targeting proteinuria, and we target the slope. Later on, we look at these slopes. So your kidney function definitely does decline from the age. But so in other words, most 80-year-olds will come to you and may only have a GFR of 65 or 60 or even 55. It doesn't mean that they've got kidney disease. If they've got hypertension or urine ACR that's also high, then those are the patients you really have to tackle. And it is especially in these elderly patients where a KFRE score is very important. Because if you get an 80-year-old whose eGFR is 55, they've got no albuminuria, and their KFRE score is 0.5%. If you get 85, your chances of needing dialysis are 0. So mostly what you're going to be doing in that patient is managing their cardiovascular risk, and that doesn't necessarily have to be managed by a specialist.
Okay, we've got lots of questions.
That's fantastic. That's what we need.
Yeah, it's great, isn't it? So someone's asked a question about what's effectively resistant diastolic hypertension. A patient who has well-controlled systolic blood pressure with an ACE1, ARB, calcium channel blocker and a diuretic, but their diastolic is still above 90. They haven't given us EGFR or an ACR, but any suggestions for how to approach that?
Okay, so I think hypertension is a different talk, but I'll definitely happy to tackle it here. The SHEP, these are famous studies, SHEP studies, systolic and hypertension in the elderly, really established that the systolic blood pressure is the one that is dangerous. It's not to say that diastolic's not, but you will also notice most of your older patients will have fairly low diastolic blood pressures because their vessels get stiff. But I do tackle in younger patients, if I'm doing 24-hour ABPMs and I see that their diastolic loads, that's the number of readings that is more than, it varies during the day, it will be 80%, 80 millimeters of mercury. At night, it will be lower, 70. If I do see people with diastolic blood pressure, the way that we're going to do that is all the usual drugs will work on those, ACE inhibitors. But if you're on all those tablets already, ACE, thiazide, calcium channel blockers, then this is where beta blockers have a role. So in these patients, if I've got them on 3 agents, including a thiazide, I tend to start looking at beta blockers if they're safe to use. They tend to, anything where I can sort of slow the heart rate down a little bit will generally help the diastolic blood pressure. Getting fit and healthy is also the other way. Exercise really
helps with that.
Diastolic, yeah.
I just want to clarify a few things. So someone's asked, with regard to the KFRE, what do we mean by kidney failure? And what we're talking about is end-stage kidney failure. So that's kidney failure that's going to result in the need for dialysis or transplant. Is that correct?
That's correct. So kidney failure risk score stands for the risk of progression to kidney failure requiring dialysis or transplantation. So that's referring to somebody whose EGFR will be below 10. So it's giving you a prediction at a specific point in time. So it's not the ideal test. Of course, remember, if you're managing blood pressure well and you've dropped the ACR, when you do it again the next time, the KFRE will be in fact lower. And that's, again, a great tool to motivate your patients and show them how well they're doing.
Motivational tool, yeah. Just a couple of other sort of just sorting out definitions and short answers. One question is, should the GP consider starting finerenone or should it be sent to the renal specialist? But there's no requirement on the PBS that it's initiated by a renal specialist. So we can start it, can't we?
Definitely.
Yeah. And
that's why we're talking tonight. I need you to. I cannot do it on my own. No nephrologist can. We have to be managing these together. Yeah. I've given you a little idea that you can use it as that add-on, like spironolactone, but in type 2 diabetics, it's an add-on. Each drug offers protection. And if you've got diabetes, you know that most patients on our dialysis machines are diabetics. So these are the patients we really can make a big difference. Yeah.
And just a timing for the ACR. So does it have to be first morning or can it just be a random urine for an ACR?
So most people are doing them random. If you want to go into the history, which I love about this original test was done by a guy called Raganenti, Italian, and he did it where he compared the 24-hour urine collection, and it actually should be the first urine specimen after you've passed urine in the morning, because it's albumin to creatinine ratio, and in truth, when you're lying flat overnight and you wake up in the morning, your urine will probably be a bit dilute. So the creatinine ratio will be slightly different. The original.
That's the first one after that one.
Yes.
Right.
So that in that original trial by Roganenti, they did it. They had to have passed the urine, and it had to be in the morning, and it had to be 4 o'clock in the afternoon, before 4 o'clock in the afternoon. But in truth, 99% of our patients are giving us a urine ACR after they've passed their first morning urine specimen, and then they're going coming to our practice or going to the lab. So, and it's usually between up to about 4 o'clock in the afternoon. So we're probably getting it at the right time.
If you think about how you're ordering it, you're probably ordering a cholesterol as well, because you're assessing cardiovascular risk. So you've written out your form and it says lipids fasting and then ACR and HbA1c. So they're going to be given a urine bottle when they go to the lab, which is going to be in the morning, but it won't be the first wee that they do in the morning. So that works out well. In a patient with no hypertension, but they do have CKD, someone's asking, is it better to introduce an SGLT2 or an ACE1 or an ARB? I want to say why not have both, but
so the PBS is saying you should be on the ARB first.
For CKD, right.
And PBS says you should be. But PBS does allow you, if a patient didn't tolerate an ACE inhibitor, but it's very rare that people don't tolerate it. And that's one of the biggest weaknesses of ARB, because it drops kidney function and causes hyperkalemia. People start these and then never go back and start them again. You should put people on these drugs, even if they do decline or acute. There are so many studies that have been published in the last 10 years that have shown keeping people on ACE inhibitors, ARBs, even when their EGFR, if they've been on it when it's above 20, even when it's 5, 10, 9, 8, 7, it actually delays decline in kidney function. So it's a combination therapy. When I tell you those are the 4 pillars, you want your patient on all 4 of those pillars if you can get them on. There are patients, they're very occasional, where they will have ACRs or ARB that will give them a problem. But I still always come back, even later on down the line, if I can't control the blood pressure, and I've got them on the other agents, I will try and introduce an ARB or an ACE inhibitor again. So you're protecting your patient, you stopping their decline, you're protecting them cardiovascularly. All the trials that had patients on these drugs had ARB or an ACE inhibitor.
There's another question about LDL goals for statins, but you made it quite clear that the study that demonstrated benefit didn't even measure LDL or cholesterol. Like for cardiovascular, if they've got a high cardiovascular risk, which you've done through the cardiovascular risk calculator, you probably should be aiming for an LDL of less than 1.4, because your cardiologist will love you. But if you can't get it down to that, and they don't have symptomatic cardiovascular disease, so they don't meet the requirements for the new medications for cholesterol, having them on any what they can tolerate.
Yes, so I'll tell you, the SHARP study and the KDIGO guidelines. So the study I remembered finally, it's coming to my head, the SHARP study. That SHARP study did not do lipid tests before. It was purely based on the ACR. And in fact, the KDIGO guidelines for CKD management do not require nephrologists to repeat lipid levels once you're on these drugs. Your cardiovascular risk. The only reason we stop them is because occasionally these drugs cause problems. We've seen vasculitis and all the other things. So, of course, in those patients, you go for the newer agents that are now available to us. But we are not like cardiologists. We are a bit more basic as nephrologists. We're just happy that they're on ezetimibe and HMG-CoA or a lipid, anti-lipid agent, a statin. So absolutely not essential. I do track them once a year, but it's not a big deal for me. I'm more likely to look at it if they've got associated cardiovascular disease. But if they've got renal disease, I don't want these patients to die from a stroke or a heart failure or heart disease. And that's the reason I'm doing it. And I know that if you've got CKD, you're going to die from that more than you're going to need dialysis.
So there's some questions that are asking, can we do stuff? And the answer is yes, but it won't necessarily be covered by the PBS. So one of those questions is, can a patient with CKD but no albuminuria be given an SGLT2? And I think the answer is if they've got diabetes with an HbA1c of greater than 7, they can be given it for the diabetes indication, but they can't be given it on the PBS if they don't have albuminuria.
No, so in fact, they can.
Or am I wrong?
No,
okay.
they can
I'm
now.
happy to be proved wrong.
Yeah.
That's
So
changed.
that has
Excellent.
just changed now. And that is this particular slide that I want to show you here. So this orange, this purple area. So you can see if you have a GFR
right,
below
between
45 and
right.
20 and 45. So the key is if you are just CKD alone with no proteinuria, you still qualify for empagliflozin and dabigatran.
If you're at that level, not at the early stages.
Yes, so it's not an EGFR of 75. Your EGFR has to be lower at 45, but you don't have to have
proteinuria at that level.
At all.
Right.
So
that's
the answer
really
is yes.
Yes,
these
depending
trials,
on that.
And that's what happened here. Credence was diabetics only. DAPA became CKD. EMPA was more CKD, bigger range, and included those whose EGFR was below 45 and more than 20. So, and then later on DAPA, there are trials with dabigatran that included this group also to get PBS approval. So now the PBS approval is for those two criteria there. So this is a drug for CKD, and that's why we spoken. You can give dabigatran or empagliflozin as a CKD only drug.
Fabulous.
You qualify. Yeah.
Now, I don't think I'm going to get to all of the questions, so I'm trying to really focus on the ones that are about CKD. So there's one about solitary kidney, but we're not going to get there. And I do want to point out to people in the Q&A that Kylie has put up a link to the Kidney Health for Life portal, and that's for patients, and it helps give them a lot of information and motivation to, and also reassures them that we're doing the things that we should be doing. So
if I don't tackle all the questions, I promise I will write a reply to all of them and pass them on to the PHN.
Great. I've answered the question that Christina made me pay attention to. There's a question about dyes on CT scans and angiograms, and I contrast-induced nephropathy in people with CKD. It just says can contrast affect EGFR, and it can. So is there?
Yeah, of course it can. So, and it's really a lot of if you look at contrast nephropathy protocols, it's mainly people who have got advanced renal failure that are more at risk. So GFR is important. Having diabetes and a low GFR seems to be more important. So definitely, I think any patient with advanced renal failure, you need to look at drugs, and contrast you can look at as a drug, and you've got to use less contrast or alter the dosing of drugs, and that's what it means. That mnemonic that I pointed you out for the sick day plan, is about looking at those drugs. Any nephrotoxin you do have to alter based on GFR. And I don't know them off by heart. I always have to look at a lot of them.
If you're ordering something with contrast and the pre-questionnaire at the radiology place reveals chronic kidney disease, they will ask you to provide a recent EGFR to help them do their risk analysis.
And they will often give a saline infusion before to prevent AKI.
Yes, yeah. Elderly patient, 88 years old, EGFR less than 25 and diabetes, are already on pillar 1 and 2. How hard do we work? They've had long-standing CKD. They're not going down like let's assume that they're just gradually going down. They haven't suddenly tanked from 45 to 25. Would you still be trying to get the extra 2 pillars on for that person?
So I may not push for a GLP-1 if they're not obese or at all of
yeah.
And I would try and get finerenone because it's not a complicated drug to use. It can cause a bit of hyperkalemia, so you may
hyponatremia as well. So just need to watch. Yeah,
but I still would. It's a pretty safe drug. It's certainly safer than using ACE or ARB. You do reduce their cardiovascular risk. You do reduce their hospitalizations, So I would try and get them on at least the 3 drugs. The GLPs I may not. But first do no harm, and I can't tell you it's right or wrong. I don't push it for every 80-year-old to get them on everything, but if I can and they're well 80-year-old, I will.
And I'm not going to ask any more questions. I think there's only 2 that haven't been asked. There's a comment from someone saying it would be really nice if the ACR used the same units, because it would be less confusing. And Stephen, I would agree with you. So thanks very much, Ivor. That's been a really helpful presentation, and I hope it helps everyone feel a little more confident in taking on the management of CKD in their patients, and being more proactive and interactive with our renal physicians, so that we can share the load of sorting out these patients.
Thank you, Martina. It's been a pleasure doing it with you. And I think it adds to the value when we do it together. I think it just makes it a more worthwhile, and I hope that everybody who was here tonight appreciate that as much as I did.
Thank you.
Wonderful. I'd just like to say thank you very much for a very engaging and informative session this evening. It's great to see so many questions from the participants as well, which makes it tailored to your needs as well, which is great. Carly also made us aware and wanted to flag that it's World Kidney Day. I believe it's the 12th of March, so just flagging that for later on in the week. But thank you everyone for participating. Thank you to our presenters, and I'd like to also just remind you that the evaluation will pop up on your screen afterwards, and we would appreciate your feedback from the session. Thank you everyone, and have a great night.
Thank you everybody.
Thank you everyone.
Thanks Ivor. Thanks Carly.
Thank you.